Shocks like the cost of living crisis, shocks like, and not so much in our setting in Scotland, but things to do with climate change, migration, crises going on globally as we speak. So it's very important to think about how these outcomes show up when they're shock. So the populations who have health inequalities are often described as vulnerable, which I think is a term that we should move away from. And because there's nothing innately vulnerable about the individual, but it is the circumstance around which they exist that makes them vulnerable. So quickly talking about the life course, we're going to focus on early years, a bit about adolescence, the middle age, and finally on aging. So this is the bit I'm mostly interested in, obviously, because I'm an obstetrician gynaecologist. Shocking for me to find that in Scotland, pregnant people are more likely to live in impoverished conditions than the general population. And right now in Scotland, we are facing a crisis where, compared to the rest of the UK and a lot of Europe, we have the highest levels of childhood poverty. And specifically, having a newborn in your family increases your chance of experiencing economic deprivation. So in a way, having a baby is a beautiful thing, but it is also a shock to the system that makes you more vulnerable. So in Scotland, I think households-wise, about 1 in 4 households, you have children who are living in economic deprivation. And what we see is that this correlates also with rates of stillbirth and neonatal mortality. We have, again, this gap when it comes to people who are living in economic deprivation, experiencing higher rates of stillbirth and neonatal mortality. Our rates, as you can see in this graph here in Scotland, are gradually coming down. But over the years, we've seen some spikes. This is UK-wide data that many of you will be more familiar with regards to, so it's embrace data, looking at morbidity or mortality in this case for mothers, pregnant people, and their babies. So again, similar finding as the rest of the UK, people living in economic deprivation, pregnant women and people living in economic deprivation are 2 times more likely to die in pregnancy than their counterparts. And the same applies to their babies. And when you dig deeper into other intersections, such as ethnicity and race, which is something I'm very interested in, is you see similar patterns in that regardless of the ethnic and racial group, you're more likely to have higher rates of stillbirth, maternal deaths, again, higher levels of deprivation. But when you tease that out, what you see at the UK-wide level is that Black women are 4 times more likely to die in pregnancy than their counterparts. Asian women are about 2 times more likely to die in pregnancy than their counterparts. I've not presented it on this data here today, but you can maybe make reference to a previous presentation where I spoke a bit too much. And there's a link on the SPSP website. So we did a webinar on racialized perinatal inequalities. When you disaggregate the data by ethnicity and look at the socioeconomic classes, what you find is that actually the most affluent Black, African, and Caribbean women still have worse outcomes, them and their babies, than the poorest women, white women. So again, it's not just about socioeconomics. There's other factors going on, which when it comes to things like race and ethnicity, you have to think about systemic racism, institutional racism. And this is where we can play a role with regards to our culture in our workplace. Now, mental well-being, 1 in 3 of us, unfortunately, are currently living with some kind of mental health condition. And in the UK, suicide is the leading cause of maternal deaths. That's also because of the way it's being classified, but this is a figure that many people are not familiar with. When you dig deeper into other intersectionalities with regards to mental well-being, you see that groups who, again, economic deprivation, but people who are part of the LGBTQ community are more likely to experience and report poor mental health. Young people, and in particular young boys, are more likely to report mental health issues. People with learning disabilities and people with physical disabilities and long-term illness, again, more likely to experience and report poor mental health. And that's really important because I actually think your mental health is actually more important than your physical health. But for various reasons, stigmas and taboos, these are things that we don't address. And the resources around it is also, I think, not enough and inadequate. So substance misuse, when you look at the data in Scotland, is a bit concerning in that in the last, well, since devolution, what we are seeing unfortunately, is a slight rise in death. So I'm presenting here presentations to hospital with regards to alcohol and drug use. But when you look at the mortality, unfortunately, drug-related deaths, alcohol-related deaths, unfortunately, in Scotland, we are seeing a rise in this. And again, the population most impacted are young men. So men between the ages 15 to 44. And again, what we see is this gap, and in some case, a widening of the gap when it comes to socioeconomic status with regards to admissions for alcohol-related issues. Cardiovascular disease is very important. It's a thing that'll get all of us. It is Scotland's #1 killer. So you are more likely to experience, again, cardiovascular disease and death if you live in an area with economic deprivation. Women are less likely to be treated in a timely manner, less likely to receive their appropriate treatment, but men are more likely to die prematurely. Work is very important because we spend majority of our time at work. So the conditions in which, again, we work, which is our culture, which are the hours, which is the support, issues around discrimination can directly impact our health. But also, if the conditions are positive and beneficial, again, it can impact our health in a very positive way. And this is where the NHS is very important as an anchor institution, because as an anchor institution, it employs majority of our population. It is trusted. It's not going anywhere, I hope. And so the conditions and the people who are in charge of the NHS can positively change health outcomes. Finally, with aging, so on the left-hand side here, we're looking at healthy life expectancy at the top in men and the bottom in women. And what we see, again, similar trends. The more economically deprived you are less likely to have a higher healthy life expectancy. So there's a 20-year gap between the so-called haves and have-nots in Scotland. And what's shocking in many parts of the world, so I'm originally from Nigeria, health expectancy is actually increasing. Healthy life expectancy, but in parts of Scotland, it is decreasing. And this is very disturbing. And a similar thing as well when you look at, cancer-related deaths. Again, the deprivation is, again, a significant factor. I guess I'll just pause to talk a bit about the global picture before talking about what's going on in England. So what we look at, when we look at other countries that have managed to lift a lot of their population out of poverty, so specifically China, Brazil, and Rwanda, what you see is a direct correlation with regards to improvement in health metrics. So it's not that difficult, but it's also quite difficult. But it's really important to recognize patterns in other parts of the world. But specifically in England, they have this strategy called the Core 20+5, and we've referenced it in the reading material you get at the end of this, which is basically their approach to addressing health inequalities. A very comprehensive approach, a very easy to understand approach. And I think it's very important because even though I'm an obstetrician and gynecologist and I love what I do, I think it's very important that we do less siloed working. And of course, I'm a bit biased, but women are everywhere. Okay, so we're going to be in your A&E departments, they're going to be in orthopedic clinics. So I obviously think women's health is very important, and the life course approach is very important as well. So with the Core 20, they're focusing on the 20% of the most deprived of the population, focusing on 5 key issues, as illustrated there: maternity, mental illness, COPD, cancer diagnosis, and then focusing on certain vulnerable groups such as migrant populations, ethnic minorities, and people who are in direct contact with the criminal justice system. So that's been a very quick whiz through. This is my last slide. I guess my key message is that inequalities are driven by power imbalances. So wherever you find yourself, ask yourself, how can I redress this? How can I study this? And then present the data in such a way that is humanizing and addresses the structural determinants of health. Think about the axis of intersectionality, when it comes to things like sex, gender, ethnicity, socioeconomic status, and think about how potential shocks may make inequalities you see in your local setting worse. Thank you. So that's my details if you want to keep in touch.
Thank you.